Hi, my name is Dr.
Gaukhar Baidildinova.
This video is a part of my lectures on evidence-based medicine and epidemiology. Our next station is non-randomized clinical trials. In non-randomized controlled clinical trials, the researcher assigns participants to treatment and control groups. In these trials, the control groups may be parallel or historical. Parallel groups, groups that are compared on demographic characteristics. For example, you are comparing residents of two different villages. If historical controls are used, all patients in the trial receive the study drug. The results are compared to the patient's previous condition, e.g., in a patient with a chronic disease, or to a control group from a previous study. Randomized clinical trials, or RCT, the strongest evidence-based type of clinical research and evidence in biology and medicine in principle. Better than one RCT, only many RCTs described either in systematic reviews or meta-analyses. A randomized controlled trial is a prospective analytic experimental study using primary data collected in a clinical setting. Individuals who are similar at baseline are randomly assigned to two or more groups, treatment and control, and then followed to determine the outcome of the intervention. The process of randomly assigning study participants to treatment or control groups is called randomization. Randomization eliminates the possibility of systematic error. Various tools, closed envelopes, computer-generated sequences, random numbers, can be used for randomization. There are two components to randomization: the creation of a random sequence and the implementation of that random sequence, ideally in such a way that participants are unaware of the sequence, allocation concealment. Let's discuss the advantages and disadvantages right away. Randomization eliminates the possibility of systematic error or bias. The greatest advantage of RCTs is the counterbalancing of both known and unknown mixed factors, leading to misleading conclusions. RCTs provide strong evidence of causality. The different outcomes have initially equal odds because the groups being compared are similar in their initial characteristics. Disadvantages: RCTs involve many participants, which leads to difficulties in organizing and conducting this kind of research. It also makes RCT expensive, and they are not always ethically possible, or there is no possibility of randomization. RCT is not necessary in the discovery of a highly effective, life-saving intervention for a fatal condition. If prior RCTs or meta-analyses have yielded specific results, whether positive or negative, some argue that it is unethical to enroll patients in a clinical trial without first conducting a systematic review to determine whether the trial is justified. If it is ethically unacceptable to ask for the patient's consent to participate in the study, when the patient's number needed to demonstrate a pronounced difference between groups is too large. The classification of RCTs is based on several parameters. Depending on the type of intervention, they can be therapeutic or preventive. That is, we either treat an existing disease or try to prevent it, e.g., with a proper diet, daily routine, and moderate exercise. A sample size can be fixed or sequential. A randomization unit in RCTs can be either individuals or communities. Randomization can be simple, clustering, block, stratification, minimization, and split body tests. Blinding can be single, double, or triple. The design can be matched, pairs, treatment withdrawal, parallel, crossover, and factorial. I also have 2 paid courses on Udemy. The Critical Assessment of Clinical Studies teaches how to read and critically evaluate clinical studies. It's a very great course. The same as my second course, Scientific Writing, where I tell all the nuances of how to write a scientific article or dissertation. Links are in the description box.